Good afternoon, one and all. The title of my study is Vertical Palpebral Fissure Changes After Supramaximal Horizontal Muscle Surgery, a Clinical Analysis. Large angle exotropia is often tricky to manage surgically, and in cases of exodeviation greater than 45 to 50% diopters, most strabismus surgeons prefer 3 or 4 muscle surgery rather than excessive recession or resection in one eye to avoid possible palpebral fissure narrowing and limitation of abduction. So our the aim of our study was to compare changes in vertical palpebral fissure height before and after unilateral supramaximal medial rectus resection and lateral rectus recession for large angle exotropia, and to look for palpebral fissure asymmetry between the both eyes and to assess the patient reported cosmetic satisfaction. The study included 30 adult patients with exotropia more than 45 prism diopters who underwent unilateral supramaximal recess resect procedure at a tertiary eye care center in India between March 2024 and May 2025. 12 patients were in the age group 18 to 30 years, 12 were in the age group 31 to 50 years, and 6 were above 50 years old. 16 patients were females and 40 patients were males. 7 patients had congenital exotropia, 7 had intermittent exotropia, and 16 patients had sensory exotropia. And the preoperative angle of deviation ranged between 45 to 50 prism diopters in 8 patients, 50 to 60 prism diopters in 16 patients, and 60 to 65 prism diopters in 6 patients. All the patients underwent a standardized unilateral surgical protocol involving 10 mm lateral rectus recession and 8 mm medial rectus resection on the poorer seeing eye or non-dominant eye, and all procedures were done under local anesthesia via a lower conjunctival cul-de-sac approach. Chances of undercorrection and a possible need for secondary surgery was explained to patients with preoperative angle of deviation more than 50 prism diopters. A software-based image analysis of patients' photographs was used to measure the lid fissure height. The photographs were taken preoperatively, immediate postoperatively, that is within 1 week post-op and 3 months postoperatively. The lid fissure height was then measured on the standardized photographs using ImageJ software. The average corneal diameter was taken as 11.5 millimeters, and it was used for calibration of the scale. This slide depicts how the images were processed in the ImageJ software. The average corneal diameter was taken as 11.5 and it was used to calibrate the scale. And this calibrated scale was used to measure the vertical palpebral fissure height. The key parameters analyzed were pre- and post-operative deviation in prism diopters, palpebral fissure height at multiple time points, and patient-reported cosmetic satisfaction at the end of 3 months. The mean preoperative deviation was 52.5 prism diopters. The preoperative vertical palpebral fissure height was 10.94 millimeters. These bar diagrams represents the change in lid fissure height. In the first diagram, we can see when we compare the preoperative lid fissure height value with the immediate postoperative lid fissure height value, there is around 1.22 millimeter reduction. And when the preoperative value was compared to 3 month postoperative, the decrease has come down to 0.22 millimeters, which indicates that the initial decrease was indeed transient. And when postoperative 3 month value was compared to that of the lid fissure height of the other eye, the difference was 0.2 millimeters, which was statistically significant but cosmetically negligible. Vertical palpebral fissure height exhibited a statistically significant decrease during the immediate postoperative period, with subsequent progressive normalization approaching the nearly approaching the preoperative measurement by the end of 3 month follow-up. At 3 months, the residual difference between the operated eye and the unoperated eye was 0.2 millimeters, which was statistically significant but cosmetically negligible. At 3 months, average residual exotropia was around 8 prism diopters, indicating a good surgical alignment, and patients reported a high cosmetic satisfaction with average scores of 4.5 out of 5. These sequential images show the changes in the lid fissure. We can see a decrease in the lid fissure height during the immediate postoperative phase, which then comes back to near normal stage. There are only a few studies done objectively looking at the palpebral fissure changes following unilateral supramaximal resect procedure. The key prior studies have found similar outcomes regarding transient lid fissure narrowing and high success rate for large angle exotropia. Our study adds new insights specific to Indian population. Supramaximal resect procedure is effective for large angle exotropia with minimal long-term lid fissure asymmetry. It is a safe alternative to multi-muscle surgery with an added advantage of having two horizontal muscles in the fellow eye spared. Our limitations include small sample size and lack of long-term functional outcomes. In conclusion, our approach offers predictable results with high patient satisfaction and minimal long-term lid fissure asymmetry. These are my references. Thank you.
Good presentation. Have you compared between the patients who underwent normal average levels of resect with these patients?
We have not, ma'am.
I think that there need to be 3 groups. So between the 2 eyes, and also you should compare between another, because see that one fact is it is improving. It is improving between the first post-op and the like 3 months. So it could be just a factor of lead edema also. So even I think looking at the pictures, it looks like that. So if you want to negate the aspect of that, then we need to compare between, for the same surgeon, normal resect versus supramaximal resect, and then come to the conclusion of how much is the thing contributed just by the, definitely excessive can have this, but that will be also, you have to look between the primary right gaze and left gaze, because there will be narrowing in certain cases more than like Duane's. So if that's going to cause restriction, so I would like you to modify the study further on these accounts.